Sorry for the delay. This is Gibong Lee. I'm broadcasting from Vancouver. And who here loves technology? I certainly don't. But it looks like this Zoom is allowing us to have this opportunity to talk to you 1,000 kilometers away about dementia and delirium. So thanks for having me. So without further ado, let's get started. So I'm a geriatrician in Vancouver, and I'm hoping to talk to you today about first part being dementia and the second part being delirium, so which will be delivered to you next week. And I don't really have any support financially from any pharma, so if I mention any therapy or drug names, anything specifically, then this is all from demonstration purposes, not for any advertisement purposes. And today, the first part I want to talk to you about is that just the basic, bare bone basics of dementia. But really what matters is the troubleshooting when it comes to behavioral issues with the dementia. So I'd really like to open up the floor and maybe have a quick discussion. If you got a challenging case or something specific, we can discuss. I think that might be more worthwhile to you. So I try to keep the information as simple and basic as possible. And we'll talk about the Alzheimer's disease, probably the most important for us, but there's other types of dementias I'd like to briefly talk about. And in my next session, we'll talk about delirium in a little bit more detail. Just a quick summary slides to show you that delirium and dementia are fundamentally different in that dementia is more of a progressive condition, and that's based on actual brain pathology rather than delirium, which is a syndrome of symptoms, the collection of symptoms that happens. It's reflecting something else is going on in the brain that's really bad. There are very many differences. Today I'm going to be talking to you about dementia, and it will become very apparent to you that delirium is a very different species entirely. So let's talk about dementia and some of the symptoms of dementia and the practical tips. So basically this is going to depend on what symptom does a patient have and how do we troubleshoot it. There's no pill that I can give everybody with dementia. This is a dementia therapy. There is no such thing. It's really going to be based on the specific needs of that person. And I think all of you have some exposure to dementia. You probably know this already, but let's pull it out to the open, okay, and we can examine it in more detail. So I do really want you to participate and ask questions and participate in your own opinions and discussion. Otherwise, this session is not going to be about here's my information and here's a quiz at the end. It doesn't work this way. So let's quickly talk about dementia. What is dementia? Well, the common misconception about dementia is that dementia is a disease. No, it's actually just a collection of different things that presents as a functional and cognitive impairment. And there's no such thing as a diagnosis of dementia. There's the diagnosis, which could be, say, for example, Alzheimer's disease, and dementia is a description of that condition. So let's stop here and think about this for a second. What makes a dementia a dementia? It's about the function. If you have a condition that affects your cognition and that impacts your function, now that's a dementia. But if you have the same condition and you're able to function, then you don't have dementia. Maybe we call it mild cognitive impairment, which is a kind of a red flag. It's a pre-dementia-like state, but really the bottom line here is the function. Can you function with this condition? Just like many other psychiatric conditions, really, that's where we draw the line. So let me give you a scenario. What if you have a person who has neurodegenerative condition, and this person, in a few years, if I had a crystal ball, is going to have dementia? But this person is functioning fine at home. Does this person have dementia? So that's a topic of much heated debate. So the term that we agreed upon is preclinical Alzheimer's disease or preclinical Lewy body disease. Okay, this is more of a retrospective condition. but it's more of a research purposes. But really, if you don't have any impairment in function, you don't have dementia. As simple as that. What if I give you a scenario? What if I got a gentleman who is 70 years old and he's forgetful, but he's doing fine at home? He sometimes asks questions multiple times, but he's happy with the answer. He goes on with his life. He can do everything in his ADLs and IADLs. Does he have dementia? It should be pretty simple to you. He does not have dementia. He scores 15 out of 30 on MMSE. Pretty bad. Does he have dementia? No. He could score 0 on MMSE, and he's still functioning well, doing fine at home. He does not have dementia. He might have other conditions, maybe learning disability, maybe he's illiterate, but if he's functioning fine, that's not dementia. What if I told you the same person, the 7-year-old, was a rocket scientist, he's working in NASA, but he's so forgetful that he forgot to tick off this one thing. I don't want to pass any blames, but maybe he crashed the rocket. Does he have dementia? Now you can say he has dementia, right? Because now it's affecting his occupational function. Does that make sense to you, what I'm getting at? So you got to have the cognitive condition that affects the function. That's the bottom line. And you have that dementia is not normal. If you have dementia, that's not normal. Old people don't get dementia because they're old. You could have some cognitive dysfunction, a little bit of processing speed, maybe a little bit of forgetfulness, but it shouldn't affect their function. If you have functional impact, not normal aging, okay? So now that we established that, let's keep going. So DSM-5 diagnosis of dementia is pretty straightforward, okay? I don't want you to memorize any of this, but it should really make sense to you. Somebody with some cognitive impairment, and the cognitive impairment, there are different domains of this. And that includes things like your ability to remember things, right? That's the most common. Your ability to speak, your ability to perform motor functions, or critical thinking, more executive thinking, visual spatial, social functions. There are many different domains of the cognition. You've got to have some impairment in one of the above. And like I mentioned in the DSM-5, this has to impact your function socially, occupationally, or just general ADL function-wise. And this cannot be due to something else causing it. For example, you can't call it a dementia if you have an acute, say, psychotic disorder. Pretty straightforward, right? I think I beat this one to death. Now, is dementia common? It's a yes or no question. If this wasn't an exam, would you get this right? The answer is yes, it's common. How common is it? Well, over age 65, 10% of every older adult in US data, 10%, and over age 80, it seems to increase quite a bit, 20. Now, interestingly, there's a general trend that the epidemiology or prevalence of dementia seems to be lower, and I think that might be because there's some theories around this, but maybe we're doing better, like our health is better, or that our education system is better. There's something about the cohort that's coming up. The prevalence is a little bit lower than the previous generations. But this is all comers of dementia. And what comes under the actual diagnosis of dementia? That seems to vary. So let's examine this together. Quick question. What's the most common type of dementia diagnosis?
Alzheimer's disease.
You would be partially correct. So as an individual entity, absolutely, that's by far the most common. But the real answer is actually mixed, because it seems that you don't seem to have just one type of dementia without having some form of vascular issue. So mixed dementia as a final diagnosis is the most common, but if you look at the actual subtype, Alzheimer's disease by far. So look at the numbers on the screen, 60 to 80%, very, very common. Okay, but all of them seems to have some form of a small vessel disease vascular. I don't think it's avoidable in our population with hypertension, diabetes, and dyslipidemia. Everyone seems to have some degree of it. Okay. Now let's give you a case. I kept this case very simple intentionally so I can add more flavors to this to give you some demonstrations. So you probably met this gentleman. He's 78 years old. He lives at home with his wife, and he's not concerned. His wife is concerned because George is forgetful, losing keys. He walks outside, and sometimes he doesn't wear the jacket. You know, it's not dressed for the weather, and vice versa. He's one time he asked his wife, "How do you turn the TV?" And she helps him, and then he says, "Thank you. What is your name?" He didn't recognize her. And there's another time he got lost in the mall walking, and then police found him and then had to escort him back home. A quick survey. Are you worried about George? Well, I'm worried. His wife is worried. George is not worried, but we should be worried. Does it sound like dementia to you?
Folks on the chat are saying yes.
Okay. Well, I kept this case very simple. I didn't give you any details here intentionally. So this could go either way. This could be dementia or this could be delirium. And the key information to find would be the onset and progression. Okay, so the same case, we're going to come back to it, okay? And this week, I'll use this case as a dementia flavor, so I'll add in more details as we go, okay? But we should be worried. There's something cognitively upsetting about George we should talk about. So there are domains of the cognition we talked about. And in George's case, he seems to have some memory problem. He's got some confusion with time and place, and some executive dysfunction, okay? And apraxia, familiar tasks, so like turning on a TV. Every man should be very familiar with their remote control, so something's seriously wrong here. And we can talk a little bit more in details about the personality and mood and things like this. All dementia, at the end, they look all the same. Doesn't matter if you got Alzheimer, vascular, or Parkinson's, Lewy body, what have you. They all look the same towards the end in terms of their presentation or their brain pathology. They look very similar. So what matters is the onset and progression, their trajectory. That's going to tell us the clinical diagnosis. Really do biopsy to get diagnoses. So something we're most familiar with, Alzheimer's disease. So I'm hearing some of you are experts in Alzheimer, work with Alzheimer's Society. So this should be your bread and butter. And in fact, this is a bread and butter for most people dealing with dementia, by far the most common, right? So what is it? What is an Alzheimer's disease? So Dr. Alzheimer, this actually young lady in her 50s, that was the original description of Alzheimer's disease. And a little bit different than what we typically see, because we tend to see people later on in their lives. And what we're seeing is usually this is a key point, this gradual onset and this slow gradual progression of the cognitive problems. So that's the key. So you can't really pinpoint, I don't know, when did I start having trouble with the memory? Most people, I don't know, maybe a year, maybe a couple of years ago, they can't really pinpoint. They can only remember certain examples when this happened to George. So that's the key point. It's slow progression. And in fact, retrospectively, if you did a very detailed analysis, you might have to find pre-dementia signals, behavioral changes, or word finding difficulties, or say some memory testing, like even before the clinical symptoms present. But as far as we are concerned as clinicians or caregivers, it's a gradual onset. Why does this happen? Basically, I describe it as these garbage proteins, the amyloid plaques and neurofibrillary tangles. These are proteins that are just misfolding, and they're not jiving very well with the rest of the cells, and it just deposits in different parts of the brain, and depending on where it deposits, it will dictate your symptom. It seems like they really like the memory component, like the hippocampus, for example, and that's where the problem is, and that's where the symptoms appear slowly over time. Okay, and most common area seems to be the memory, the short-term memory, and then eventually the long-term memory. It's a different part of the brain that gets affected. But another thing is a language. Okay, so what I mean by language is that, you know, that word finding difficulty, just the tip of my tongue. You know, that thing there the other day, that inability to articulate your exact point. No problem with reading, but just coming out, just the tip of your tongue. That seems to be a common place to start. And then the rest of the apraxia, executive dysfunction seems to follow after. Does that sound familiar to you? Oh, I just thought it was a really cool picture to show you, but what I'm trying to show you is that at the end stage of Alzheimer, the entire brain gets affected. In the beginning, you will see that there is a very specific pattern like hippocampal atrophy and entorhinal atrophy. There's things that you can see on the MRI scans that may help us, but clinically it's not really that important what I find on the MRIs or brain autopsy or biopsy. It's a clinical, the history, the story that the family members and the patients tell me. That's how you get the diagnosis. Quickly, I want to talk about vascular dementia just because it's the second most common, and also it's the most common mixed type of dementia it contributes to. There are two major types you can think about. One is that this obvious, boom, you had a stroke, and all of a sudden you're a functioning person, now no longer. That's the obvious vascular dementia. It's in your face, you can't miss it. Now, there's a second type that it's more difficult. So this is a small vessel disease. And this is something that you get when you have hypertension, you know, diabetes, cholesterol, things like this that slowly accumulate over time. And then you can see it on CT scan as well. There's in certain patterns called the periventricular whitening. So you can see it on CT scan. So that's how we know. It's a little bit more difficult on history because they sound actually very much like Alzheimer, more gradual, okay, and more insidious. Okay, but the presentation is a little bit different than the Alzheimer. In that, imagine you had a stroke in an area where you speak, the speech center, then that's where your symptoms are going to be. And if the problem is in the motor area, that's where your problem is going to be. So depending on where the stroke is, it's going to be different presentation. But overall, it seems pretty common that a lot of the people would have more of a visual, spatial, and executive dysfunction. What I mean by that is their memory might be okay. They can remember, you know, they can manage their tasks like, say, medications or what have you, but they seem to be just getting lost, just driving for executive function, something more of a high, you know, filing your taxes. Okay, going to an office to get a certain documentation before you can do the next task. You know, your ability to organize your life seems to be the most important area that gets affected. Just think about it like when you're sleep deprived, or you just had your baby and then you're just not organized. That's what vascular dementia likely feels like. Your inability to organize yourself in a way that you can process higher level thinking. I think everybody here probably identify with that. Questions about this so far? So the Alzheimer's disease and vascular dementia, the combination of these two, it's the most common mixed dementia. And Alzheimer's, as I mentioned, these proteins that are not really welcome depositing into the brain, as opposed to the vascular dementia. I mean, the name makes a lot of sense, right? This vascular problem in the brain, and then you have dementia as a result. Now, there's a couple of other ones that I just have to tell you about just because they're just so interesting and so different. The Parkinson's and Lewy body dementia. These two are, I think, describe it as more of a spectrum of conditions. They're very similar. So Parkinson's dementia or Lewy body dementia, we call them two separate things just for prognostic purposes, because of Lewy body dementia is much, much worse. But their features very, very similar. So to imagine somebody has a Parkinson's symptoms. You know what Parkinson's look like. They're stiff, they can't walk. Everybody imagine what Parkinson looks like. Now, add dementia on top of that. So your diagnosis is gotta have Parkinson's symptoms, you gotta have dementia, you gotta have functional impairment. But their features are so interesting. They have hallucinations, and they've got very discrete visual hallucination. You see things that are not, not just lights and colors, but discrete humans, animals, children, things coming out of the wall. And they have very distinct sleep disorder. When you're talking, or sometimes you can act out your dreams, that can be quite distressing to the bed partner. So we call it the REM sleep behavior disorder. Very interesting feature. And those are the things that we can target and actually treat. So it's really important for us to get this diagnosis. There's a lot of things we can do. Another interesting thing about Lewy body is that sometimes it looks like delirium. It fluctuates. Some days George is good, some other days he's terrible, and some days he doesn't even know who I am. Some other days it's almost like George had no dementia. That fluctuation, that's the interesting thing about Lewy body. Now, have you heard of frontotemporal dementias? If you've seen it, you'll never forget. There's different variants of it. I'm going to focus on the behavioral variant because that's what really matters to the caregivers. But in seen frontotemporal dementias? Oh, I'm sure you've seen it. Maybe you didn't recognize it. So frontotemporal lobes of the brain, they control a lot of what makes us civilized people. So especially the frontal lobe. You're thinking it, but you're not saying it. What makes us do that? It's our frontal lobe, the filter. And what happens when you drink? Nobody's saying anything, but you're all thinking it. But what happens when you drink is that the inhibition of the frontal lobe is lifted. What you're actually thinking is coming out. Imagine that all the time. It's not exactly fun for others, right? So the behavioral variant of the frontotemporal dementia, especially the frontal component of the frontotemporal dementia, makes you lose that frontal inhibition and you become this disinhibited person. And you have personality changes. You could be obnoxious, you could be rude, or it could be just simply just unfiltered. There's some other behavioral things like this ritualistic. You've got to be a certain way. You're very rigid. I can't deviate from it. It's almost like going into some behavioral disorders like, say, autistic spectrum. They've got to do things a certain way. They become very rigid, cannot do it any other way. And they change in their appetite habits, so they only want to eat certain kind of food, usually sweets. So basically like a childlike behavior. So that's the frontotemporal dementia. Remember the example that I gave you earlier? Say somebody who has a MMSE score of 15 out of 30, but functioning fine, they don't have dementia, right? Now, this is the opposite case where you can have 30 out of 30 on your MMSE and then have complete dementia. Because the frontotemporal area may not impact your MMSE score. Your memory might be fine, your language might be fine, but you just don't have the behavioral control. So that's the opposite example of what I told you earlier. But does it affect function? Does it affect your occupation? Does it affect your social circle? Just think about it. Imagine you're drunk all the time. Could you go to work? Could you have friends? Well, more like, could you keep your friends? That's frontotemporal dementia for you. Interesting, right? Questions about this so far?
There's been a comment online. If you could comment on primary progressive aphasia and how it's different than Alzheimer's dementia.
So primary progressive aphasia, where are we? Is a part of frontotemporal dementia. So it's a different variant of it. Behavioral variant is one type, and the primary progressive aphasia, the aphagic variant, is another type. And that's the temporal lobe. So temporal lobe is where you have the Broca's and Wernicke area that does a speech. One listens, the other one speaks. And imagine you get atrophy in that area. So that's what they look like. They often come in with mistaken for Alzheimer's dementia because they can't seem to remember, they can't seem to speak. And if you actually do their memory testing, there's nothing wrong with their memory. They can remember, but they just can't tell you because the speech is impaired. So this is a very interesting, there's different types. One type is that your verbal motor control is impaired so that you sound like you're talking gibberish. There's another type who is mixing words up. They're saying things that are proper words, the words itself enunciated properly, but it's not making any sense. It's almost like I think about Trudeau versus Trump kind of situation. One makes no sense, the other one makes sense, but there's no content. Does that help you understand the primary progressive aphasia? It's another common mistake between Alzheimer and the frontotemporal dementia is a logopenic variant. The debate, is it actually Alzheimer or is it a frontotemporal dementia with the logopenic variant? Because they can look very similar. Logopenic as in lack of words, inability to say the words that you're thinking about, you know, the tip of your tongue scenario. And they can look very much alike. And in fact, at the end of the day, what gives it away is a progression. Because the frontotemporal dementias, they happen quickly and they progress very quickly. Their prognosis is much, much worse than Alzheimer. And in fact, frontotemporal dementias happen early in their lives, usually if they're middle age, 50s, and then progresses quite quickly. Oh, I just realized there's a chat room that's active.
Yes, I've been trying to read from that, Dr. Lee.
Oh man, sorry, I had the chat room closed, so why don't I just keep it open?
That's okay. I've been trying to just follow up. I don't think we've missed anything. You've just missed folks' answers to your questions. One follow-up just recent from Rona.
Yeah, I got it.
Perfect.
Okay. So the thing about dementia, depending on which type, the initial onset and progression differs, but it doesn't matter what the cause is, eventually they all spread. So like I said earlier, they all look the same at the end. There's no way I can distinguish Alzheimer versus, say, Lewy body or frontotemporal dementia at the end stage if I see them for the first time, just because the entire brain's going to be affected no matter what. So what's going to give me the diagnosis is a retrospective, the story. How did it start? How did it progress? But the actual testing, physical exam, or memory testing, none of it's going to be useful towards the end. They all look the same. But why do we care about the diagnosis? It's because the prognosis. Okay, quick memory testing for you. Okay, so you can do this in your own head, but let's do the key features. Number one, Alzheimer. What are the key features of this we talked about? Yeah, your gears are cranking, right? So if I was to summarize Alzheimer's disease, it's a slow progression and a gradual onset with a predominant memory component and the language component. So tip of the tongue phenomenon, just can't remember things. That seems like the prominent feature of Alzheimer, and the rest of the features gradually come later. Okay, next, vascular dementia. How would you describe that? I would remember vascular dementia as something as unmistakable. It's a boom, you had a stroke, something seriously bad happened, and then you have now major changes in cognition. And that could be vascular as in stroke, ischemic stroke, could be hemorrhagic stroke. Traumatic brain injury arguably could fall into the vascular dementia as well. Okay, not technically, because the traumatic brain injury usually doesn't progress like the vascular dementia does. As far as I'm concerned, in terms of your management, I think it's the same approach. Now, what about Parkinson's versus Lewy body? This is a little bit more interesting in that you've got to have some Parkinson's symptoms, and then you've got to have dementia, and there's all sorts of interesting associated features like hallucinations, kind of like delirium, fluctuating up and down, changes during the day, and also this sleep behavior. If you're suspecting this, okay, these are the stories that you've got to get. And now frontotemporal, I've given you different types. There's actually 4, but the ones that to focus on is there just unusual behavioral changes that I just can't explain. This is just not George. Like, what's he doing? This is just not something he would do. The other type is that your lack of speech. Okay, let's a quick memory check there. How did you get out of 4? This is an extensive delayed recall test. Be passed. Okay, now let's get back to the case. Remember George? He's 78, lives at home, and wife brings him in because his short-term memory is bad. Losing keys, he's forgetful, and he's got executive dysfunction. He's not thinking about the weather and clothing appropriately. Now he's got some apraxia too. He doesn't know how to turn the TV anymore. And he's clearly got some agnosia, doesn't recognize the wife. And visual spatial, getting lost in the mall. So he's got all these components of the cognitive domain, and he's definitely not functioning well at home. Okay, now for this part 1, I'll give you some descriptors and try to come up with the diagnosis. Give you a hint, it's going to be one of those 4 we talked about. What if I told you this has been going on for last 2-3 years? Just gradually worsening. At some point, he lost a key, didn't think much of it, and he's lost a second one, and now I have to make it a keychain out of a necklace so that he doesn't lose it. Can't trust him with nice things anymore. Okay, what does that sound like to you? Right. So does it sound like Alzheimer's disease? First of all, it's a dementia, not delirium, right? Because it's been going on, gradually happening, and that on. Oh. The onset and progression sounds like Alzheimer's, correct? Now, what if I told you the same gentleman, his description is like this. You know, George was fine up until last winter. And then he was really sick for a while there. I don't know, he couldn't eat, you know, he couldn't walk. He was in bed for a few days, and he just never been the same since. What does that sound like to you? Yeah, it sounds like something happened to him quite urgently, and there's some kind of medical issue there. And this is a story that I'd be worried about vascular. So this is when you do CT head and things. Maybe he had a bleeding there, like a subdural hematoma, something like that. Or another possibility is that he could have had delirium then and never recovered from the delirium. Okay? And what if I told you that George has been doing this for some time now, in the last year, and some days he's totally fine, some other days he's not, and George doesn't go out anymore because he's falling a lot. He can't walk, and he's needing a lot of help. But some other days he seems to be doing fine. It's almost like he's doing okay. But you know, I don't know what happens to him at night anymore, because I haven't slept with him in the same bed, because you know he just kicked me all the time. Does that sound like Lewy body? Yeah, so this would be more of a Lewy body. So someone's asking if the vascular dementia can be fixed in some cases. No. Once you have damage, that area is dead. What you could expect is that if this was a delirium instead of dementia, there's a reasonable chance of recovering. But once it turns into a dementia, that's it. There's no cure for dementia. Okay, what if I told you this gentleman also has a drug habit, and he likes to drink, and when he's sober, this doesn't happen. He's completely fine on other days, but when he's intoxicated or he's recovering from a bender, this is when these things happen. Now, this is a curveball. So this is not a dementia. It's a secondary to substance abuse and only happens exclusively in the setting of this substance use. Then this is not a dementia. How do you fix this? Well, extensive counseling and multidisciplinary approach, but you just got to stop drinking. Well, I mean, I wish it was that simple, but I mean, that's the bottom line. Okay, so the frontotemporal dementia doesn't present this way. Usually there's no other cognitive domains. Usually memory is intact and he's able to get around, and that's the problem, because they look fine and they can do a lot of things. They're very functional, and this is where the danger is, because these are the people that will leave, these are the people that drive, and what do you think about their insight? Take a guess. Do you think people with frontotemporal dementia have good insight into their issue? Right? So they just don't have the filter. And it's like basically you have a malfunction in a sensor that senses yourself. Yeah, so that's where the problem is. The first thing to go is your self insight. And these are very, very challenging cases. Okay, and I'm pretty sure after this description, many of you have seen this, or at least suspect it. You can look around your caseloads or even people around you. You probably have seen someone like this. Okay, so let's talk about this management. The management for dementia is very challenging, and there's no single thing that you can do to fix everything, right? So that's going to be multifactorial, multi-component. Let's talk about Alzheimer's disease. I think the good place to start is education to the patient, but they'll probably forget, so maybe the family members need to get involved as well. So caregiver support. The prognosis from the diagnosis is usually around 5 to 10 years mortality. Most of them end up dying from complications of pneumonia. That's by far the most common. And either pneumonia or aspiration pneumonitis seems to be the most common reason. Some people lose weight and functional decline, hip fractures, but that's by far the majority of the cases. Really, it's going to be about, the dementia is about function. Therefore, your therapy should focus on the function and prevention. So things like, if they don't have any good insight and they don't dress well for the weather, making sure that they are well supported so that they don't leave in the blizzard in a t-shirt. Having some kind of a tracking device for them so that if they were to get lost or if they leave the house, someone gets alerted. If they fall, there is a way to alert them. So some kind of a safety net, protective device, tracking device, that's going to be a major treatment option for these people with dementia. Now there's a lot of questions about exercise, brain, and the physical exercises. The physical exercise actually has really good evidence. So getting your heart rate up has good evidence for Alzheimer and also vascular dementia. I mean, it's pretty obvious, right? You got vascular risk factors, treat that, and exercise is good for it. And physical exercise seems to reduce the incidence of Alzheimer. Once it sets in though, once you have a diagnosis, it doesn't seem to make a huge difference for the brain function. But guess what exercise helps you with? Your physical function, therefore ADLs. So I strongly recommend it. And it's good for the mood as well. So it seems to have less behavioral issues. And I think a lot of it has to do with the boredom too. If you got dementia and everyone's just worried about you, don't let you do anything, they're bored, and that tends to lead to more behavioral issues. Therefore, physical exercise seems to be a really good way to get them distracted. So I highly recommend it. And that could be something as simple as walking outside. Doesn't cost anything. Brain exercise, on the other hand, multiple trials looked at this, the specific like memory exercises or visual spatial exercises didn't seem to improve MMSE score. However, though, it's same thing as a physical exercise. It seems to keep them occupied, seems to keep them happy. Therefore, there's a good behavioral outcome with it. So I strongly recommend just getting off the television, reading materials, things like this. I'll get to the drugs in a bit. Diet and nutrition. So I don't know if you heard about the Mediterranean diet. I actually had a fairly large trial on this, high contents of polyunsaturated fat, so, olive oil and such. And it seems to have a really good benefit in prevention of the Alzheimer and vascular disease. Again, once the dementia sets in, none of the dietary supplements or the dietary lifestyle has changed the trajectory of the dementia, but seems to be mostly prevention. Now, when is it useful? People with mild cognitive impairment. The patients, they have some memory changes. They score badly on MMSE, but they seem to be functioning. So they don't have dementia, but cognitive impairment for sure. These are the people I think will benefit the most from dietary and nutritional changes, exercises and brain exercises. Okay? Now, really the key. Keto diet, I'm actually not sure if there's any actual hard evidence for keto diet and dementia. If you know anything specific, maybe you can share with us. Okay, in the meantime, troubleshooting the specific behaviors. That's the part that really got to focus on. Okay, we're going to talk about this in the BPSD component coming up. Okay, let me come back to this. Drugs. So Alzheimer's disease. So the drugs that you know of, donepezil, rivastigmine, the cholinesterase inhibitors, and memantine. So these drugs, they do not alter the dementia process. What it does is that it seems to slow down the testing score, not actual disease. It's not a disease modifying. Your dementia still progresses, but when you start these therapies, like donepezil, your MMSE score goes up. So I think there's a temporary benefit to their memory. And basically the bottom line is this. Do they work? Yes. Do they work well? No. So when do we use it? It seems to have benefit for, the people just functioning just a borderline state, safe at home, not safe at home. When these patients get on cholinesterase inhibitors, they seem to keep them at home a little bit longer. So the way I see cholinesterase inhibitors is to buy them some more time before extra help is in place. Okay, there's no cure for dementia. And memantine seems to do the same thing as I mentioned. It's more indicated for severe stages. Both of these seems to have some benefit in behavioral components, agitations or like hallucinations and things like this. So when they have specific behavioral issues, it's worth a while. But they certainly have some side effects like weight loss and cardiac side effects. So you need to think about this. And I'm not a big fan of these drugs because the benefit seems to be so modest and they're not cheap. So if you're going to spend the money, I say hire somebody to help them exercise. I think it's a much bigger bang for your buck. Vascular, quite simple. Manage your vascular risk factors, hypertension, diabetes, dyslipidemia. Once it sets in, there's no specific cure or therapy for vascular dementia other than behavioral things we're going to talk about. Parkinson's, Lewy body, there are lots of very specific therapies, such as cholinesterase inhibitor seems to help with the hallucinations, some memory impairment, and of course, treat the Parkinson's, right? Frontal temporal dementia, ooh, these are tough crowd. Nothing really seems to work for them. Nothing works for the dementia. It really got to be the component of the behavioral issues. And let me tell you, it's very, very tough because they don't have psychosis, but they're acting like this belligerent people. And that's totally different from their baseline personality. Very, very challenging. And some SSRIs, some antipsychotics we may try, but it's really going to be about managing expectations. Very, very challenging crowd. Let me quickly say, the benzos are very specific for the REM sleep behavior disorders. The benzodiazepines stops you from dreaming, therefore stops you from acting out your dreams. Okay, you got to be really careful because they fall off like nobody. So it's a very, very dangerous therapy, but works for a lot of people. Now let's talk about the side effects. So antipsychotics, I really hate antipsychotics because a lot of these people are having symptoms. They're not psychotic. They're having dementia-related behaviors. So I really try to avoid them unless have actual delusions, hallucination, the actual psychosis of the dementia. Because what happens when you take antipsychotics? It's really not the antipsychotic dopamine blockage you're looking for. We're actually using them for sedatives. So what happens when you sedate a demented old person? They fall, they aspirate, and die. The mortality rate of the patient starting antipsychotics in the first 2 weeks to 4 weeks, the first month, is that you need between 20 to 30 people to take the drugs to die from the antipsychotics. Number needed to harm is ridiculously high. If there's a psych resident here, okay, I want you to really remember this. The antipsychotics have high mortality rate in the first months of therapy due to cardiovascular, stroke, aspiration, okay? Very, very dangerous. But you've got to use it when you got to use it, when the behavior gets out of control, okay? So use your clinical judgment. So let's talk about these behaviors. BPSD, that's really the biggest component of dementia. Mood, apathy, agitation, or full-blown psychosis. Hypersexual, like masturbating in public, in long-term care, going into other residents' room for sexual approach. It's challenging. Or in the end stages, just straight up yelling, no purpose. repetitive noises, okay? Some ritualistic behaviors. These are some of the behaviors, only some. This is not an exhaustive list by any means. And managing these individual behaviors, that's the key to dementia management. At this point, let's open up a table. Any comments or special case you want to discuss? Okay.
Can I just ask about, you know, you're down on antipsychotics, and I agree, but, you know, there still seem to be the go-to for a lot of doctors, mainly because they're bothered by their call from the nursing home and the nurses don't have the time for behavioral things. Like there's a whole list of things that don't respond to antipsychotics, but we're using antipsychotics for the very purpose you mentioned, which is simple sedation. Well, is there an alternative medication we can do in those people who have these things that bother the nurses? You know, the wandering, the yelling, kind of.
Well, sure, yeah. So let's talk about this in a general approach. So it has to be individualized. I think really the key to behavioral management is the time. You got to spend the time. So there's got to be some investment. If you invest the time up front, it will save you the time later. So let me tell you what I mean by that. The approach to a BPSD, the behavioral issues, is really the assessment. What is the behavior and why are they doing that? Okay, let me give you an example. Let's say this patient that I had was banging on the table. And that was bothering a lot of people, and, you know, he was labeled as aggressive, you know, like more violent because of the banging on the table. And we looked into this a little bit more, and it seems like it happens 6 a.m. early in the morning, okay, and goes on for a few hours, and then happens later in the evening again. And there's no specific trigger, but he seems pretty rigid when this happens. You just gotta let the course finish. And turns out, what was happening is that he was a dairy farmer, and guess what he was doing? He was milking the cows. Surprise. So you know what we did? We blew up a glove and we tied it at the end so that it looks like, you know, glove looks like this. And he started milking the glove. And he never needed antipsychotics after that. That was the only behavior. I'm giving you this best case scenario, simple fix. I mean, the world isn't that wonderful, but I'm only giving you one example to think about. To describe that behavior. What is the trigger? Why is he doing that? And if you can figure that out, okay, a consistent nurse or family members, they can help you. Sometimes you don't need the drugs. Sometimes you don't need the antipsychotics or sedatives, okay? And next part, what happens if you just let them be? Like, for example, yelling, wandering. The person is wandering, you let them walk. If they're ambulatory, do we need to keep them in bed? Not necessarily. We just lock the doors and let them walk. So this is another common thing, is that what is the actual risk of walking compared to keeping this person locked down to the bed? So antipsychotics or physical restraints in combined results actually has more harm of injury than walking and falling. And we have data for this. Unless the person is just so obviously cannot walk at all, actually the better therapy is to let them walk. Okay, and the other thing is that the yelling. The best thing to do is to see if the yelling is based on some kind of a discomfort. Like, you know, like a baby. Your baby's crying. What's your first response to a baby crying? Well, I mean, the first thing you should do is weigh the baby so you can give him 2 milligrams per kilogram of sedatives, right? No. The first thing you should do with a baby crying is to figure out what's their intrinsic need. Hungry, thirsty, cold. And you should do the exactly same thing with a man, woman with dementia. Maybe they're yelling for some kind of an intrinsic need. Once you address that and you're sure that this is a dementia behavior, at that point you think about what is the risk of just letting them yell. Put them in a quiet room, close the door, check in on them every once in a while, but you don't need to give them antipsychotics in that case. Okay, if you have the luxury of that space. Yeah, that's exactly right, Lori. Yeah. Do we need to change that behavior? Okay, so Annie, you're asking psychotic disorder with the fixed delusions. Yeah, so this gets really tricky. And teasing out actual psychotic disorder versus dementia, oh man, this is a tricky situation. And just probably some of the most difficult part of my dementia behavior is actually dementia or is it psychosis? There is no quick answer for this one. Okay, it's going to be more of a capacity. Like, do you understand? Because in a psychotic disorder with the fixed delusions, they have good thought process, poor insight, poor judgment, but they have good reasoning why this is happening. As opposed to if it's a dementia behavior, that executive function goes, and their ability to reason their thought process is not going to be there anymore. Okay, so that's probably where you should start. Okay. And next thing you should do is a troubleshoot, and then you intervene. As you're asking, some people, you've got to give them something. They're agitated, they're violent, you've got to give them something. Well, you know, it is what it is. In a situation where they're at risk of harm to themselves or others, you've got to use antipsychotics. But before you do that, make sure there's no other psychiatric needs, such as anxiety, very common. Maybe controlling that anxiety can control the behavior. Maybe that's the cause, such as SSRIs. Okay. And I really try to avoid the benzodiazepine for obvious reasons. Okay. And maybe there's some other medical issues that's upsetting them. Maybe their bladder is full. Maybe they're constipated. Some other issues you need to address before you go into the sedatives. But at the end of the day, if there's a harm, immediate harm at play, you've got to use chemical or physical restraints. But all I ask you to do is do this assessment first. Okay? And the key word here is that look at it from the patient's perspective. Why is this person doing that? Because maybe it's not the behavior we're interested in, it's the cause. What's driving that? Okay? So it's not a magic solution. You've got to spend the time. You've got to invest your time and energy into it in the beginning. And that's why the geriatric consult's 2 hours long. Okay, I hope this was helpful. This is not it. In next week's session, if you want to come back and further discuss this, because like I said, really the money is here. The discussions. It's not the pathophysiology or epidemiology that I presented to you. It's really what we're doing right now. That's really the money. So feel free to come back, okay? And I'll have the same slides. Okay, let's continue our discussions, and then we'll touch on the delirium as well. Any last minute burning questions?
Do you have a favorite? Do you have a favorite? Which antipsychotic do you use? Everybody seems to be wanting us to give them Seroquel. Really bad Haldol.
Sure. I would spend. How about this? I will spend a little bit more time on the antipsychotics with the delirium talk. It's actually quite similar. Okay, and I'll spend a little bit more time on this.
Yeah. Just want to know which ones are the worst ones to be using and what to look out for with them.
Mortality, the worst is risperidone. The best is quetiapine. And it seems to be the effectiveness is the reverse. Quetiapine works the least amount, but risperidone works the best. So it's a trade.
Okay, thanks.
All right, see you next week.
Thank you, Dr. Lee.
Yeah, thanks. Yeah.
Thank you.
Okay, bye-bye.
Thank you so much. Good job, Lee.